Hello everyone, welcome to Healthcare Improvement Scotland's webinar on continuity of care in general practice. There are still a few people joining, and so we'll give it another minute or so before starting the session properly. However, whilst we're waiting, please could you answer a couple of questions in a poll that should appear on your screen so that we know who we have joining today and where you're joining from. There is also a question that's going to come up in the poll asking whether or not you think continuity of care within general practice has improved or worsened in recent years. So the poll should just be appearing on your screen just now. And if you've answered the poll, you can scroll through to see the responses as they're coming in. There's about 47 responses so far. So I'll give it another 30 seconds or so before we start properly. So we've got a good mixture of people joining today from different parts of Scotland and from elsewhere in the UK. So welcome everyone. My name's Paul Baughan. I'm a GP. I'm a clinical lead with Healthcare Improvement Scotland, and I will be chairing today's webinar. We're going to start by going over some housekeeping, which I will get up on the screen just now. We're recording the webinar so that those unable to attend today can watch it later, but there's no need to worry if you're camera shy. Cameras and microphones have been disabled for delegates. And what you write in the chat will not be transcribed in the recording, although I may refer to specific comments posted and use them to steer the direction of our conversations over the next hour. This webinar differs from the normal Teams interface in that there's a Q&A function next to the chat box, which can be used for specific questions that you want to ask. We will try and answer as many questions as we can during the webinar. However, relevant questions that we do not manage to cover will be answered afterwards and posted on our Healthcare Improvement Scotland website. Please note that questions specifically relating to political decisions or contractual matters are out with our remit, and so whilst they may be relevant and you may wish to highlight them, we'll not be able to give you an answer, much as I'd like to try. So, why focus on continuity of care? Well, many of us were attracted to a career in general practice due to the opportunity to provide holistic, person-centred care, focusing on the individual rather than the disease or illness, and helping people through the course of their illness, learning and considering how their health impacts on their family, their social life and work, and reviewing people over weeks, months, or often over many years. And this is known as relational continuity of care. And there are a number of books that describe the satisfaction that GPs have experienced from providing such care, such as John Berger's account of a local doctor in 1967 called A Fortunate Man, followed in 2022 by Polly Morland's account of A Fortunate Woman. And guess what? Research confirms that outcomes for both patients and for health professionals are better when we provide this relational continuity of care. However, research has also shown that continuity of care is decreasing for many of our patients, and that was demonstrated in the poll that you completed a couple of minutes ago. What we are hoping to explore today is why this is happening and what, if anything, practices can do to change it. The format of the webinar will be 2 short presentations from experts in this area, followed by a panel discussion where we can explore some of the issues in a little bit more detail. So I am delighted that joining me today are speakers who have a wealth of knowledge, expertise, and practical experience of continuity of care within general practice. Our first speaker is Dr. Carrie Lunin. Carrie's been a GP for many years, working in areas of high socioeconomic deprivation. She is a past chair of RCGP in Scotland and the current chair of the Scottish Deep End project. She's also an honorary senior clinical lecturer and a senior medical advisor to the Scottish Government. And following Carrie, we will hear from Dr. Kieran Sweeney. Kieran is an academic GP based in the University of Edinburgh, where he is a Wellcome PhD Fellow. He works clinically at St Triduana's Medical Practice in Edinburgh, and his research largely focuses on evaluating primary care reform in Scotland, measuring quality of life in people with multiple long-term conditions. He is also part of a working group to expand the measurement of continuity of care within general practice. So over to you, Carrie.
Thank you very much, Paul. It's great to be here today. Thank you very much for inviting me to be a part of this. And really over the next 10 minutes, I was hoping to give a little bit of a whistle-stop tour, a précis of what we mean by continuity of care, some definitions, some evidence base, some of the challenges and barriers that Paul was alluding to, but also thinking about what are the significant opportunities and challenges, opportunities for change that we have as part of this important part of care. But we're keen to get to the meat of the discussion and hear from you about what your experiences are too. So, thinking first of all about continuity definitions, there are 3 main ways in which continuity of care can be considered and defined, and I just wanted to quickly go over those. First of all, informational continuity, which means that we're allowing high quality information transfer following the patient. That can be written or verbal, and really that should be there for everyone. Management continuity, where you have an agreed and coordinated plan and an agreement about who is responsible for doing what, which is most relevant for people with complex conditions. And relational or personal continuity of care, which is seeing the same person over time to allow the development of trust and a therapeutic relationship. And of course, all 3 types of continuity are important and they're interdependent, and the effectiveness of healthcare systems relies on having all 3 of these dimensions of continuity. It's also probably important to note that relational continuity and relational care are not the same thing. They're intertwined but separate. And as healthcare professionals, we have a duty to provide relational care at every encounter, regardless of whether or not we're likely to see someone again or whether or not the patient is our patient, if you like, in terms of someone that we know well. So just going on to the next part of this, thinking about the issues around continuity of care and what makes it difficult. I think I had a different slide up there, but I'll go through this one. So the access and paradox is something that comes up a lot, and we think a lot about the definitions of continuity of care and access as being in competition with each other. But of course, they have to be mutually present for healthcare to work. You need to have access to be able to offer continuity. And when you have good continuity, you can also reduce access. But there is a complex interplay often between access and continuity of care, which is shown in this slide. Just in terms of the published evidence base, there are lots of papers describing continuity of care and what the evidence base is for why it's so important. And the current available evidence base for the benefits of continuity of care is largely about the 3rd definition that I explained at the beginning, relational continuity of care. in the published literature, this is almost exclusively about relational continuity of care over time between a person and their GP. And we'll come back to that because, of course, today we're talking about the modern general practice landscape, which is much more about multidisciplinary models of care. But we know that relational continuity of care has been shown to improve these things. It improves patient satisfaction. It also improves clinician satisfaction. It develops trust, and the impact of developing trust in primary care means that people have trust within the wider systems of care within which they receive care. We know it improves adherence to medical advice and prescribed medication and reduces waste. And we also know that it improves uptake of personalised preventative medicine like vaccination and screening. It improves quality of care and it reduces workload in practices, which is a very powerful argument for why this is so important, depending on who we're needing to persuade. But certainly for these benefits shown in this slide, it's likely that many of these positive impacts would also be shown with general practice nurse patient continuity, that general practice nurse colleagues being the other generalist colleagues within the system who have longitudinal care relationships, particularly with people who have complex long-term conditions and are often the ones that are giving advice about medication adherence and preventative treatment. So just thinking about the second slide of evidence base again, it goes on. We know that if you have relational continuity of care, that you have lower rates of hospital attendances and admissions, you have lower costs in whole healthcare systems and less overuse of medical procedures, lower death rates, reduced complaints and litigation, and clearer lines of responsibility and accountability because people know who it is that they're meant to see, and people have a clearer understanding of someone being the person that they are caring for. But an important part as well of having relational continuity of care is being able to better address health inequalities, which in Scotland, of course, is really important because we have the worst health inequalities in Western Europe. Relational continuity of care supports the development of trust, it supports earlier disclosure of illness and of life circumstances that many people might find stigmatising or shameful. And continuity of care is often hardest to achieve for people living in poverty, but when it is achieved, it's often an important part of the treatment and of the care itself, rather than it just being a model of care delivery. So given the overwhelming evidence for benefit for patients and for the NHS and for clinicians, if continuity of care was a drug, we'd probably want to put it in the water. But what we know is that despite the compelling evidence base, we've seen a fall in continuity of care as measured by the HACE scores, the survey that's done every couple of years. And here we see the scores from 2020 to 2021, which are measuring relational continuity. And we show that this has the lowest positive and the highest negative score at the bottom of the slide on the right-hand side. Moving forward to the next HACE survey that was done in 2024, we can see that relational continuity wasn't actually, in fact, measured, and it was replaced with informational continuity, where the question being asked was, did you know the healthcare professional knew my medical history? Now, of course, going back to the original definitions, informational continuity is also important, but it's not the same as relational continuity, and it isn't associated with all the positive benefits that I've described. So there is an argument that we should keep measuring relational continuity in our HACE surveys. And we also know that this fall in relational continuity as experienced by patients is also experienced by GPs. This is one of the RCGP tracking surveys that's done every year. This is back in March, showing that around 2/3 of GPs said that delivering relational continuity of care is the factor that motivates them the most about working in general practice. And certainly it's the reason I chose to become a GP, but that more than half of GPs feel they're not able to deliver relational continuity of care in the way that they would want and that would meet their patients' needs. So we know that relational continuity of care, of course, is not just fallen in general practice, but across the whole of the NHS. We're focusing on the general practice story today because that's the audience. But I guess that it's important to say that because general practice is not by any means the worst offender. It's just that the impacts of the loss of relational continuity of care are disproportionately greater because of the scale and the longevity of patient encounters within general practice and primary care. So the question is, How do we make the most of the workforces we have based on the evidence we have to support relational continuity of care for those who need it the most? Or as I've heard it described, how do we try and aim for proportionate continuity? So it feels important to understand who stands to benefit the most. And this is what the evidence base tells us. People who are older, people who are frailer, people in end-of-life scenarios, people with multiple morbidities, complex long-term conditions, people with more significant mental health and addiction problems, people living in poverty, all benefit from relational continuity of care. And I've put everyone in brackets at the bottom because in an ideal world, everyone benefits. It's always good to speak to someone that we feel knows us, so that we don't have to repeat our story. But we have to start somewhere. We have to start with the people who stand to benefit from it the most. Can it be measured? Kieran's going to talk about that next, so I won't mention that just now, but other than to say, yes, it can. But I just wanted to think a little bit about our current landscape of general practice and what is making it feel more difficult to have relational continuity of care within our modern general practice. We know that, for example, over the last 10 to 20 years, we've had a rapidly growing multidisciplinary model within general practice, and we've got almost 5,000 new colleagues who've joined us, which is fantastic for many reasons in terms of widening skills and experience, but we know that can make care feel more fragmented, so it's important to understand how do we try and avoid that. We also know that our general practice nursing workforce is declining, although our advanced nurse practitioner workforce is increasing. And as I mentioned, general practice nursing and longitudinal care relationships is an important part of what we're trying to achieve here. And we also know that declining GP workforces, both in terms of full-time equivalent and headcount, has also decreased over the last 10 years, which means that we've got a rising number of patients registered per GP. We also know we've got a decline of personal list systems where people are more likely to be registered with a practice rather than with a named clinician. And we've got a rise of telephone triage models and on-the-day services, which was happening before COVID, but very much became more common during the COVID pandemic for infection control reasons and has persisted on and is sometimes the main model in some practices across Scotland, which can make it difficult to deliver continuity of care. We've also got an increase in less than full-time working in clinical practice, and we've got recognition of the emotional labour of relational care. To stay in relationship with people, particularly people who've experienced adversity or trauma through thick and thin over a long period of time, does generate emotional labour. We don't hear that spoken about as much, but I think it's important to recognise it and understand it and be able to support it if we would like people to be able to deliver more relational continuity. And we've also got a culture of speed of access being king, which is driven by many different parts of the system, politically, publicly, and probably also professionally as well. So thinking about continuity and access, I think it's worth a slide on its own because these are often principles that are kind of competing against each other, but they also can complement each other. So we know the relationship between continuity and access is complex. It's dependent on factors such as need, demand, capacity, and prioritisation. We know that timely access is really important, dependent on need, but if we have a singular focus on speed of access, that this can have unintended consequences for relational continuity. We know that access to care is a prerequisite for being able to provide continuity of care at all, but we also know that when relational continuity improves, access also improves. So perhaps it's about widening the definition of what we mean by access. That might be a useful conversation so that it's not just thinking about speed or activity levels, but it's also about access to relationships. So thinking about how it can be achieved in the modern general practice landscape, thinking about what it means in practice, and then the final slide, which is the next slide, what it means in systems. In practice, thinking back to the definitions, informational continuity is important really for all patients, and that involves good note keeping, good record keeping with clarity and accountability and information sharing, managerial continuity for patients with more complex conditions, which in terms of enabling factors means time to meet, discuss, learn, plan and document management plans. And relational continuity is often about identifying who are the high risk or the high priority cohorts and agreeing named clinicians, thinking about buddy systems and thinking about micro teams for those who most need relational continuity. And in terms of the bigger picture stuff, what this means for systems, there's lots of different layers that we need to be thinking about to try and make this feel more of a possibility. We need to be teaching it for our future workforces. explaining what the evidence base shows, exposing people to what relational continuity of care feels like and the benefits of it during training. We need to be able to measure it and track improvement. We need to be able to understand more what continuity means in an MDT context through more research, through the demonstrator work, which is why we're here today. We need to engage patients and teams and why it's important. We need to improve through existing quality mechanisms, for example, through cluster working. Innovate using digital to support relational rather than replace it. Thinking about what does it mean to incentivise it through contractual levers? How can we do that in a useful way rather than a damaging way? And how do we prioritise it in NHS reform plans and CMO work streams and other things? So I apologise, that's a lot of information to cover in 10 minutes. What I'm going to do now is I'm going to pass over to Kieran, who's going to talk through measurement for the next steps. And thank you very much for listening, and look forward to the chat with the panel later on. Thank you.
Super, right. Thanks, everybody. The next 5 minutes there is to talk about how we can measure continuity in general practice. And so we're going to start with some key points and then look at a couple of specific examples of methods, and then signpost to some useful resources if you're interested in starting to do this in your own practice. So the first point really is about why this matters. And in order to improve continuity, we're going to need to be able to measure and to monitor it so that we know whether the changes we're making are improving things. And so to do that, there are two kind of fairly straightforward and certainly widely used methods to measure continuity in general practice. And that is the usual provider of care, UPC, and the St. Leonard's Index of Continuity of Care, SLIC. So that's what I'm going to introduce us to today. And then the third point is just really about the direction of travel. And we're starting to see measures of continuity become integrated and accessible on health board primary care data dashboards like in Lothian. And in the near future, that's going to be available on national dashboards. So that's really encouraging developments, but there may still be advantages and reasons why you might want to know how to do this in your own practice. So let's have a look at that. We'll start with the usual provider of care. So if we're going to frame this as a question, it would be something like, for patients who consulted 3 or more times in the past year, what proportion of their consultations were with their most seen doctor? So how would we answer that? We would do a search that brings us up a list of patients, all those patients who had at least 3 consultations looking back over 12 months. And we want it to report the count for each of the clinicians in the team, as well as the total count that patient had over the year. When we then export this to Excel, for example, the only thing we need to do then is add a formula here which divides the highest count by the total number. So this patient saw Dr. Jones 3 times out of their total of 5 consultations, and their UPC score is 60%. And we can repeat that for all of the patients in our list, and then at the very bottom take an average of all of these scores, which would be the practice level UPC. So keep that in mind, and then we'll look next at the SLIC score. So if we phrase this as a question, it would be, what proportion of consultations in the past month were with the patient's named doctor? And immediately you can see a couple of differences there, not least that it stipulates a named doctor. So SLIC is really only suitable for practices with a personal list system, which is in 10. But how would you go about implementing this? Again, run a search that this time that would give you a list, not of patients, but a list of consultations, all of the consultations in the past month. And you want it to report who the consultation was with and who the patient's usual doctor or named doctor was. And then the only bit of number crunching that you do in Excel is to add a formula here which asks, does this column match this column? Yes or no? And you do that for your whole list of consultations. And at the bottom, you calculate what the proportion of yeses effectively. And that is your SLIC score for the practice. So just to kind of reflect on a couple of the differences there, the St. Leonard's Index, the SLIC score is just looking back 1 month. And the advantage of that is that it's going to be quicker to reflect change when we're doing quality improvement work. But it does require us to be able to stipulate a named doctor. And by contrast, the UPC is looking back 12 months at least, and it needs to do that so that it can identify who the usual provider, the most seen doctor is. But that makes it slower to kind of show change when we're trying to improve things. The adjusted slick here is an idea that you might try and kind of pick the best of both, in the sense that you might look back to identify who the usual provider is in a practice which doesn't have personal lists, but then use that named doctor in a slick type of calculation. So that's called the adjusted slick, and that's the approach we're looking at taking on the national dashboard to show continuity of care. When you do measure continuity, a natural question for your practice then is our score any good? And I think I would say on this that a good score is one that is better than your last score, because really this is about improving and comparing yourself to yourself rather than comparing between practices, not least because these scores are strongly associated with things like practice size and other practice characteristics. Nevertheless, there are some kind of benchmarks for what is considered good scores, and slick of 50% is considered good. That means a patient half the time is having an appointment with their named doctor. And there are places in throughout England, and I'm sure in Scotland, that are delivering that. In UPC, a big study showed that an average score in England is also around 50%, but a big range from about 30 to 90% linked with practice size. So just to round up, if you're interested in kind of starting to do this within your own practice, then feel free to get in touch with us. We've got some e-myth searches that you can directly import, some user guides about how to crunch the numbers in Excel, and it won't be long before we have similar for vision, I'm sure. The RCGP toolkit is worth having a look at, and we can perhaps talk about that a bit more later. It's got some resources around measuring continuity. And then as I've said about the dashboard, certainly in Lothian, you can see your practice UPC score without having to touch a spreadsheet if you don't like them. And certainly progress on a national dashboard is underway, which is really exciting. So that's enough from me. Thanks.
So thanks, Carrie and Kieran. Huge amount of information there for us to digest. Please, as I see you're doing, please add your questions to the Q&A box or comments and thoughts in the chat, and we'll look at these as we go along over the next half an hour. However, I'm going to ask Carrie and Kieran to join a panel or sofa session now, along with 3 practicing clinicians. If we can take the slides down, that would be really helpful. I'm delighted to invite Rebecca Grant, a general practice nurse with 6 years experience working across NHS Ayrshire and Arran and NHS Greater Glasgow and Clyde. Rebecca has a keen interest in chronic disease management. We also have Andrea Davidson. Andrea has 29 years of primary care nursing experience, first as a district nurse and then as a GP nurse. She's the lead nurse for GPNs in NHS Forth Valley. And finally, Mary Barr. Mary is a GP partner in Mabel Medical Practice, a GP trainer and a representative on Ayrshire's local medical committee. I should mention that Ayrshire and Arran are one of the 4 demonstrator sites with the primary care phased investment programme, and they've seen some additional investment in pharmacotherapy and CTAC services, which work alongside their ANPs, their practice nurses, their mental health nurses, their advanced physio practitioners. And so, Mary, when I was visiting your practice in December, I was conscious that your practice team has expanded considerably over recent years. And so I was wondering if this expansion in your MDT has impacted positively or negatively on continuity of care, and if there was anything that you were doing in your practice to encourage continuity.
Yes, so I mean, I would say overwhelmingly positive for us. I think we all know the challenges and the pitfalls when it comes to embedding MDT within our practice, particularly when those are health board employed individuals, but overwhelmingly positive for us in our practice. And as you said, because we have been a demonstrator site, we've been very early adopters of the full MDT. So we've been fortunate enough to have physio, mental health, pharmacotherapy, all embedded pretty quickly. Where I'm sure we're the same as most practices, where we feel like we could always be doing with more, but it's been very positive. I would say for myself, with regards to continuity of care, I've found that to be a tremendously helpful team approach to looking after patients. It's really helped me to see my patients more consistently, because there's shared care now, whereas I would have a huge caseload of patients coming in with mental health problems that I maybe didn't know very well, or MSK problems. I feel so my caseload now is not as dilute. I don't know if that'd be the right word to use, but I do see a lot of my own patients back consistently, and then I'm able to have team discussions about those patients. So particularly, I would say with mental health colleagues, I'm able to share a lot of information back and forth, and we can kind of in tandem look after those patients. I think you asked about what we've done to try and encourage continuity of care. So firstly, we have a very highly supportive, very highly motivated practice manager who really pulls the team together. Our admin staff, when they are signposting and when they're looking at the calls, they'll, generally speaking, if they're able to, ask the patient which clinician knows them the best, or which clinician they would prefer to see on this occasion. Obviously, with more urgent cases, it's not always easy to do, but we try to get people back into who they're familiar with. And then the other thing that's worked really, really well for us is having a hybrid template. So obviously with COVID, everything pretty much went to all on the day appointments. I know there will be a lot of practices who kind of have to work that way to deal with their workload, but we use a hybrid template, which means there's lots of opportunity for us booking back in our own patients, for patients to book ahead with the person they want to see.
That's excellent. Yeah, because that's something that we sometimes have difficulties with, where, I'll be seeing someone with a complex care need that I would like to bring back to see me, but I know that when appointments are short, I sometimes hesitate to suggest that because I realize the person will struggle to get an appointment. So that's one way that you're using to enable that person to get an appointment. Okay, that's really helpful. Moving on to Andrea, Rebecca, a lot of what we've heard today relates to continuity of care with GPs, but general practice clearly involves many disciplines and many different professional groups, general practice nursing being one of them. Andrea, earlier this month, a refreshed Transforming Roles Paper 6 was published. And for those on the webinar not familiar with this, it's a paper that sets out the changing role of the practice nurse. And it specifically mentions the importance of continuity of care from a nursing perspective. Andrea, can you tell me why continuity of care is just as important for GPNs?
Yep, absolutely, and hugely important. And I guess when I was sort of thinking about coming onto the webinar and thinking about specifically issues around about access for GPs, we're in a bit more of a unique position, and that isn't so much an issue for us because the numbers of GPNs within practices are much fewer than GPs in practices. So particularly for all the long-term condition management, we do have that privilege of being able to say to patients, come back and see us in 4 weeks or whatever. So we are consistently seeing the same patients and building up relationships with them, actually with their families. We have that generational continuity as well. I had a fourth-year medical student sitting in with me recently, and mum came in, daughter happened to be in on the same day, and I knew granddaughter as well. And she'd found that really, really insightful, that actually, I knew 3 generations of one family. And was able to say so much about them. So, we're in a really unique and privileged position, and just exactly what Carrie was saying, what Mary was saying, really building those therapeutic relations, that trust developing over time. We are very much about proactive, promotional health and trying to get individuals to sort of engage in their own healthcare. I guess as well, sometimes just developing those relationships over time, particularly in more sort of people who are impacted by socioeconomic factors. And sometimes they don't know what their health risks are. They don't know what their cardiovascular risk is associated with their COPD, or that pulmonary rehab may benefit them, or smoking cessation, or a handheld card that they can then rock up to the local pharmacy and get their prednisolone and their antibiotics. And I get, so much about that person having, the right care at the right time in the right place. And I guess as GPNs, that's something that we're very, very strong on, enabling patients to, to really get the best of that continuity of care and be seen by the right person.
That's really helpful. And is there anything that practices can do that could support continuity of care with the GP nurse?
So I think appointment times are really important. So really, giving that good appointment time for that really good, robust, really thorough long-term condition reviews, so that you're covering all bases. I think consistency of messaging, so both from your gatekeepers, from your reception staff, making sure that the whole team know who does what, who the most appropriate person is, and especially for our newer, team members like our ANPs, and, signposting to the GPN as opposed to the GP if there's side effects to diabetic medication, respiratory issues, etc. So I think consistency of messaging and communication, but also to the patients, so that they know who the most appropriate person is to see.
Yeah, no, it's helpful. And Rebecca, from your perspective, I know you spend a large proportion of the day supporting people with long-term conditions. With CTAC services taking on more measuring and monitoring of chronic disease, do you see that as a threat or an opportunity to improve continuity of care from a GPN perspective?
Yeah, so I suppose it can be seen as both a threat and an opportunity, and it really depends on the perspective of how it's implemented. So as an opportunity, you've got that reduced workload for GPs and practice nurses, faster access to monitoring. So there's more of a focus on patient education and treatment. With CTAC handling the measurements, practice nurses can spend more time on that patient education, self-management support, and treatment adjustments. As a threat, I mean, there is a risk of, if routine monitoring is done outside with the GP practice, patients may feel less connected to their usual nurse, so affecting that trust and holistic care. I think to maximise that opportunity and reduce that threat, strong communication between CTAC and GP practices is really important. A hybrid model for high-risk patients would be really useful. So routine cases can go to CTAC, but complex patients could stay under practice nurse management. So overall, I think probably more opportunity as long as it's managed very well. If integrated properly, the CTAC service can definitely improve efficiency, reduce workload, enhance patient access, while allowing practice nurses to focus on that education, support, and complex care. So overall, I think, communication is definitely key.
And I think what you're referring to is in terms of the hub model and people having their measurements taken somewhere else, is that informational continuity of care, making sure that information is transferred appropriately from one place to another. And that was something that Carrie had mentioned in her presentation. And, Carrie, bringing you in, you touched on briefly the current focus on timely access to general practice. And yeah, so does seeing the first available practitioner impact on continuity of care? And, what could we be doing about that within our practice?
So it's complex, isn't it, Paul? Because there's a difference between timely access and speed of access. It's a subtle difference, but it's an important one. And if we're only focusing on speed of access, regardless of the level of need, then we get ourselves into an impossible situation where we are driven just by getting through the numbers as quickly as possible. And it's really, really difficult then to prioritise relational continuity. But if we focus on timely access, as in if somebody is unwell and needs seen quickly, then they need seen by whoever is able to see them that day. And in an ideal world, that would be someone who already knows them, but it may not be. But the systems are still geared to then share that information from that consultation with their usual person, so that when they're having follow-up, for example, or they're less sick, they can still be linked back in with their usual person. So I think there is the conversations around access are often quite problematic, because I think when we hear about improving access to general practice, often what I think is meant by that is getting people seen quickly and having lots more activity in the system, as opposed to thinking about making sure that people are seen in a timely way, and perhaps having a wider understanding of what we mean by access to care, which might include access to a relationship with somebody that you already know and who knows you, so you don't have to repeat your story, and you get safer, higher quality, etc. care. So there's some cultural shifts that I think need to happen around what we understand around speed of access and timely access, and also a lot of work to be done around encouraging the public that if they were to wait for a little bit longer to see someone they know, that the system will support them in that, and that they won't have to wait a very long time, and that they can, say, for example, pre-book an appointment, which makes relational continuity of care far easier than having an on-the-day system. But there's lots and lots of challenges and opportunities around how we can change the culture publicly around why relational continuity of care is worth waiting for.
That's really helpful. And Kieran, we talked about this the other week, about accessing appointments and different ways of managing on the day urgent demand. I see there's a question or a comment from someone that's joining from Whitley Bay in North Tyneside. And I know, Kieran, you've been in contact with that practice previously, and exploring different ways of managing that on the day demand. What did you learn from speaking with them?
Yeah, so I spoke to one of the partners at Whitley Bay, which is a place that is managing to deliver kind of high levels of continuity. So routinely kind of 70-80% scores on SLIC, which is comparable to Norway. So pretty remarkable numbers. And so I spoke to Luke, who's one of the partners there. I think actually probably stepping back from how they do their on the day demand process, because I think Luke's message was really that those kind of practical steps are probably secondary to a kind of culture within the practice. So a kind of whole team buy-in to the value of continuity, deciding to measure it, and other elements of culture is kind of what do the patients understand and feel about continuity, and where might education be needed within the team, and so on. So yeah, I think getting that kind of whole team buy-in and communicating with patients is kind of more fundamental. The tricky bit is about the kind of system or organization design, and practice systems have got competing streams of work of different urgency, different complexity, doctors of different working patterns, and so on. So there's not really a one-size-fits-all answer to that question, but I was interested to find out what they're doing in Whitley Bay. And so they do have personal lists, and I think that's probably quite fundamental. And with that, there's kind of information continuity. They do, I think, have kind of acute hubs. So some of their on the day demand is dealt with by MDT staff in kind of shared hubs in the region. So that's important to note. But a bit like Mary said, they're kind of capitalizing on the opportunity that gives them to think about how they're delivering their own on the day demand. And so instead of typically having a single duty doctor that just sees a list of patients requiring an appointment that day, or seeming to require an appointment that day, the on the day demand is shared out amongst the doctors there. So they don't have one single duty doctor, but as far as possible, a kind of on the day appointment is assigned to the doctor that knows them best, to their named doctor, effectively. And if they're not there, then there's a conversation about whether actually it's worth waiting until the next day that doctor's in. The other thing they do typically, or think about, is about having their template set up, that it's that they're typically working at something like 80 or 90% capacity, that there's always that extra bit of give for unscheduled kind of callbacks, for squeezing people in, and that gives them an element of controlling access and being flexible. So those are specifics about how they do it, but it's kind of built on a culture. It's built on communicating with their patients, and so there's kind of wider things that other practices can start with rather than diving in like that.
There's a question in the chat I noticed about whether AI can support delivery of relational continuity of care. Is that something that any of you have come across?
I think where it could come in is helping us to identify and predict which patients, not which patients are most likely to benefit from continuity. I think we know that, but to flip that on its head and think which patients can we be fairly satisfied, or which patients and which presentations can we be fairly satisfied are quite safe to be dealt with, for example, in a shared acute hub by other MDT professionals or by GP that's not their named doctor. And there are patients that both value continuity less than access in certain situations and probably need it less. So continuity is for everyone, but it's not for everything. And I think AI could help us kind of work out where to put our efforts, basically.
Okay, thank you. And Carrie or Maria, a question for you. There's a question in the chat about the risk of someone being seen by the same clinician repeatedly and a change in condition not being recognised, or of the impact of a patient waiting too long to see their GP. So I suppose, does seeing the same doctor ever lead to worse outcomes? Either of you got any thoughts on that?
Yeah, this has come up for me very recently. A patient came to see me and I hadn't met them before, and it was a really complex story. And I think there absolutely can be a benefit to a fresh pair of ears and a fresh pair of eyes. And I think as long as you're I think it all comes down to communication, doesn't it? And having good buddy systems within the practice. We have that in our practices. We're a small practice, so that helps us. So we've got 4 GPs, but only 2 on any given day, with an AMP. And so quite often if I've got someone and I just think, I have looked at you for weeks and I still can't figure you out, going to your other partner, going to your AMP and saying, I need you to listen to this story and tell me what I've missed, and vice versa. One of my partners will come and say, I'm not sure what's going on here, but I need some fresh perspective. So I think it's achievable, possibly easier in a smaller practice, but achievable.
And the benefit of seeing, so I'm just thinking my own practice where we encourage continuity of care. However, I know that my 2 female GP colleagues have a much broader and deeper knowledge around managing symptoms associated with the menopause. We've got another GP that's got a special interest in dermatology. And I see a question in the chat about whether or not we should be encouraging some people to make an appointment with the person in the practice who has the most knowledge in that area, which might be an MSK physio or a practice nurse or another member of the team. How do you manage that, Mary, within your practice? Do you have particular doctors that have different areas of expertise or different health professionals that have different areas of expertise that you might encourage someone to go to?
We do for certain things. I mean, there's 3 of us female GPs and 1 male, so he'll tend to pass us all the women's health things, which is fine. I think we're all very, very aware though of trying not to de-skill, and I certainly know I am. One of my partners has a particular interest in dermatology, so I'll usually try my best before I'll then go to her and say, can you help this? Because I'm very aware for myself that I don't want to de-skill in certain areas. But I mean, shared knowledge between people is fantastic in a team, and we all bring different things to the party. So use that. Absolutely.
That's great. And Carrie, I think you mentioned in your presentation that we're seeing changes to professional working patterns. People are more likely to be working part-time than maybe when A Fortunate Man was written all those years ago. How does that impact on continuity of care, and what practical things could practices do to ensure that there's good continuity of care where GP or GPN is not working every day of the week?
Thanks, Paul. So I think there are a few practical things that certainly are being looked at much more proactively by, for example, the extra research team, recognising that working patterns are changing. Buddy systems, I think, have got some promising early results, particularly if you buddy up with someone who's not in the same days that you are. I think for that to work really well, it's important to think about how do we have kind of consistency of approach? How do we communicate well about the issues that are impacting on the patient? How do we try and ensure patient choice as far as possible as well? Because all of those things feel important for it to work well. But there's also some interest in micro teams with GPs as part of a team that has maybe a receptionist or a care navigator or care coordinator who knows the patient well, and depending on their clinical issues, maybe a mental health nurse or maybe a physio or maybe an OT. It depends on the issues that are kind of largely presenting, which is quite like the NUCA model, which you're probably all familiar with. So I think we have to develop the evidence base and better understand the evidence base of how we work best within a system where our workforce is often less than full time. Whilst also recognising that there's a bit of a chicken and an egg situation, in that some people do go less than full time because the system feels really hard to work in, and that if we had more relational continuity of care and less of a focus on just speed of access and getting through the day, people may feel able to work more sessions than they currently do. And I think the other kind of aspect of that is specifically recognising the kind of emotional labour of offering really high quality relational continuity of care to someone over a long period of time. I think it would be great to have a lot more curiosity and proactive support around supporting all clinicians to work in relationship with people over long periods of time, because it's not always easy to do well and to hold people for many, many years. So I think that there is a bit of a chicken and an egg around part-time working and continuity of care, that it's good to disentangle and think about how do we make that feel possible for people to do.
Yeah, that's really helpful. And I notice in the chat there's been several comments about the importance of practice management and admin, reception staff encouraging people to see the doctor that knows the individual best. And I've heard that there are different areas where there is something on practice websites or something on the telephone line when you phone through to the practice to encourage people to see the doctor that knows them. I'm conscious that there's lots of questions and lots of useful comments within the chat. We're not going to be able to answer them all. I'd like to ask each of the panelists one last question, which I'll go through each of you in turn. And it's really to say that there may be people on the call today who would like to go back to their practice and improve continuity of care in the place that they're working, but they don't know where to start. What advice would you give them? What one thing would you say, or where should they start? Maybe Andrea, do you want to come in on that first?
I think from a general practice nursing point of view, look at your appointment system, maybe do some patient feedback, see how things are feeling in your own practice from a patient perspective, from your staff perspective. As I said before, we're in a slightly more privileged position because of our appointment systems and because we are the only ones delivering long-term condition management. But speak to your practice manager, speak to your admin team, work cohesively as a team, just that consistent messaging. So
that's great. And Rebecca, what are your thoughts?
Yeah, I do agree. I think obviously making sure that documentation is easily accessible to all team members. So if everyone's using the same system, it's much easier for that continuity.
Mary?
I would say buddying up. My partner and I, she works first part of the week, I work the second part of the week. That works beautifully for us. And it means the patients quite often know that there is one other clinician who's familiar with their care. So someone complex or someone that you're worried about, we'll pass them back and forth through the week.
Great. And Carrie, what are your thoughts about that?
I think there's something really key about sort of winning hearts and minds of the team, in terms of explaining why continuity matters and that it's not a sort of nice to have aspirational thing from 20 years ago in Dr. Finlay's casebook, that it's actually got a really robust evidence base underpinning it, and just thinking about maybe the opportunities for, if there's time to get together as a team to think about why does continuity matter, what are all the roles that we can play within the team that are unique to us. So I would completely agree with all the comments in the sidebar about reception teams being the front line of the front line, and often the first people to get a sense check on whether someone's just not quite right. But also they are often the first person that someone speaks to when someone phones. So you're thinking about what that means in terms of induction, for example, for new staff. How do we phrase the questions that we ask to orientate people towards continuity rather than just speed of access, if speed of access isn't clinically needed? So I think there's something about coming together as a team, understanding the evidence base, what roles do we all play, and kind of winning hearts and minds so that we're all singing from the same hymn sheet, as it were, as we go out to try and make change.
Great, thanks, Carrie. And finally, Kieran, what are your thoughts on that question?
A few things. I think number one, measuring continuity. I think by measuring continuity, we're deciding to start a conversation about it, and we're deciding to think about how we can improve it. So that's one thing I think that we can do quite easily. The second thing is to think about personal lists. I think that is probably quite a fundamental thing to try and shift towards, that would improve continuity. But there's always a balance between idealism and pragmatism, I think, in any of these things. And then I think the final thing would be communicating with patients. So that echoes what others have said, but I think we could think seriously about communicating on a national level, like public awareness type work, but also on a practice level, writing to our patients saying, this is who your named doctor is, this is the days they work, this is why continuity matters, and this is what we're going to do to try and improve it, and reiterating that message, at the front desk with reception, in our consultation rooms, to really, I guess, rebalance a bit of the public conversation about continuity and why it matters. So yeah, measurement, personal lists, and communication, I'd say.
Okay, and there's some questions I see in the chat about, how can you start to measure that? So there's some resources which we will put in the chat just now, which people can look at and people can use if you want to look at continuity of care within your practice. I'm conscious of time and realize that we need to draw this webinar to a close. But before doing so, I'd like to thank each of the speakers and panel for contributing to a lively, thought-provoking webinar. So Carrie, Kieran, Andrea, Rebecca, Mari, thanks for sharing your thoughts and experiences with us. There's a lot for us to think about. My take-home messages are that continuity of care is really important for patients, with improved health outcomes, as Carrie showed and demonstrated within her presentation. But it also provides practitioners with a great deal of job satisfaction. And at a time when general practice is under so much pressure and strain, this has got to be important and something worth fighting for. So we've heard that there are some practical things that we consider doing in our practices, such as measuring continuity of care, as Kieran spoke to us, about encouraging people to wait where appropriate, rather than taking the first available appointment, and considering information that we might give to patients, whether it be on our website or phone messages, and using the skills of our admin staff. Considering clinician bookable appointments, having a named GP for the most complex patients, for example, those living with multiple long-term conditions and frailty, and exploring whether some of the urgent on-the-day work can be directed to the usual provider of care for that patient. I mentioned earlier that Healthcare Improvement Scotland is currently working with 4 areas in Scotland to evaluate the impact of MDT expansion in more detail. And there was a question about that within the chat. We will be assessing the impact on continuity of care through these 4 areas in Scotland, and that will be done through interviews with staff and patients and through examining the UPC index, which Kieran had mentioned earlier. And the learning from this programme will be shared with key stakeholders, including Scottish Government and SGPC. Before you leave, could I ask that you provide us with some feedback through the poll, which has appeared on your screen? We'd like to know how helpful the session was. what action, if any, you're planning to take as a result of this session, and what key learning or improvement ideas you've gained from it. And thanks to my HIS colleagues, to Jamie, Martina, Sarah, and Claire for working hard behind the scenes to organise the webinar. So thank you, everyone, and goodbye.